St. G.S.MEDICAL College and King Edward Memorial Hospital, I, Alhad Mulkalwar, welcome you all to the keynote session by our guest for today, Dr. Michael Glynn. Sir is a consultant physician with special interests in gastroenterology, hepatology and clinical nutrition. He was trained at Cambridge and St. Mary's Hospital, qualifying in the year 1977 and achieving FRCP in the year 1993. He took part in duties for acute medical emergencies continuously from qualifying until the end of the year 2015. He has special clinical expertise in ERCP, therapeutic upper GI endoscopy, hepatology and clinical nutrition. He currently leads a multidisciplinary national and intestinal failure team. He has been a consultant at Barts Health, Royal London Hospital since 1988 and was also at the Newham Hospital from 1988 to 96. He was the clinical director for medical and emergency at the Royal London Hospital from 1999 to the year 2008. From 2013 to 2016, he was the national clinical director for GI and liver diseases with NHS England. He is in demand as a medical legal expert within the fields of general medicine, gastroenterology and hepatology. He has a major interest in the postgraduate medical education. He is also an honorary senior lecturer at Queen Mary, University of London. He is a regional advisor for the Royal College of Physicians of London and was a censor of that college from 2009 to the year 2012. From 2008 to 2013, he was the director of the North East Thames Foundation School, which was responsible for the training of more than 700 doctors in their first 2 years after qualifying. He has been the co-editor of Hutchison's Clinical Methods, one of the oldest and the most fundamental of undergraduate medical textbooks since its 22nd edition. Sir, we are honored to have you here with us today. I now request Dr. Shami ma'am to offer Sir a bouquet as a token of her admiration and gratitude. Now, without much further ado, I would now like to invite Dr. Michael Glynn sir to take over.
Right, well, thank you very much for that extended welcome. It's really nice to be here and to see so many faces. I'm going to talk about this. Actually going to just go back through the introduction, just tell you a little bit about Hutchison. So this is him, a rather austere looking man who was born well into the 19th century but lived a long life. First wrote his book 120 years ago, and 24 editions, that's almost exactly one every 5 years. He was actually a physician and a paediatrician, something that wouldn't happen these days. He worked at the Premier London, in fact English Children's Hospital, Great Ormond Street, and at our hospital, the London, now the Royal London Hospital, and was president of 2 august medical societies. He was Scottish, he had a very thick accent, and he was quite a severe individual, but nevertheless a very, very good doctor. And he stopped his hospital appointments relatively early in his career, continued to see private patients. This is the hospital where he worked and where I worked, on the top left. The front block was built in 1747, so quite an old hospital, and then was replaced by the one on the bottom right in 2011, a very, very modern and rather fantastic hospital to work in. The book was published in 1897. First 12 editions he worked on himself, and then from the 13th edition it was taken over by colleagues, and I've now done with Professor Drake editions 22, 23 and 24. You've heard about me, so I don't need to show you that. My colleague Professor Drake, who is sorry that he wasn't able to travel with me, is a bit younger than me, qualified in 1991, went to what we call the other university, i.e. Oxford, and studied at the London, his clinical studies, and he's an endocrinologist, general physician endocrinologist. He's a trainer and a professor in endocrinology. So on to the basics of history taking. So this is actually, I'm just going to tell you the first chapter of the book, but in some detail and emphasising various points. It's no secret that it's the first chapter because it's the most basic. I've had a lot of discussions since I've been in India about how doctors and to some extent students are not studying clinical skills and relying perhaps too much on investigation, so hopefully I'm going to redress the balance for you. So what is history taking about? Well, it's pretty basic. It's about talking to patients and those around them and getting to know them. You might only see a patient for 10 minutes, that's it, emergency consultation, but you still have to get to know a bit about them. But the other's also true. I'm seeing patients now that I've seen on and off for 30 years, the same patient, so you might get to know them really rather well. They also have to get to know you as well. That's terribly important, and the trust that they put in you will depend on that relationship. You need to understand their concerns in the widest sense, not just their immediate symptom. But you do need to understand the symptoms, and you need to begin the process of diagnosis. The process of diagnosis starts really as you meet the patient. From the first moment, you're beginning to think about things, what's going on, how do they look, are there any obvious features. When you compare history taking and clinical examination, most people think that it's about an 80-20 rule, that 80% of the diagnostic information comes from the history, so hence the emphasis. And I think personally it's more skillful than physical examination. So what about setting the scene? There'll be lots of opportunities and situations where you're talking to patients. There may be an emergency consultation, maybe a hospital outpatient, it may be some sort of family doctor or office, but all of them are important. You'll need to meet and greet them, make some sort of initial observations of what's going on, and you need to work out how you're going to see them. A consultation with the doctor is often pretty threatening, for all sorts of reasons. Patients expect the doctor to bring bad news, they may just not be used to that sort of talking to a professional person, so positioning is important. In an office situation, try not to talk across a desk. In a hospital, don't talk down to them for the end of the bed. Those sorts of things are very, very important to remember. Very simple to do, but very easy to forget. And then you're going to have to manage the notes. Note-taking is crucial, not least for protection against being sued, but also just for good clinical medicine and for presentation later. That might these days be directly on some sort of electronic device. Doctors who've been qualified for a while find that really difficult to do, but actually it's not that difficult. You've got to get going, and it is just about talking, but it's about talking in a skillful way. The first question is rather important, and because it's so important, I personally think that you should delay the question about the presenting problem until you've just talked to them a bit more and they've got a bit more used to you. And getting through some basic stuff first, I think, works well. Now, I know this is slightly contrary to what's conventional teaching, probably across the whole of India, and to some extent in the book, but I just put this as an idea. The one thing about all these clinical methods is there's no absolutely standard way to do things. You do need to work out what works for you. So I think you can start off with some basic stuff. How old are they? What's their work? Work that's very relevant, often then what was their previous work possibly. I would just put the idea in your mind that you might want to take the past medical history first, although I know that's contrary to conventional teaching, but just seed it as an idea, because a lot of it's rather factual, rather simple, but it always informs what comes later, and a lot of illnesses don't have a clear split into what's past and what's present. Then there's some basic stuff which has easy answers. Do you smoke? Do you not smoke? Do you drink? Do you not drink? How much? What medications do you take? Although, as you'll see later, I think this is actually a difficult question, but it should be quite simple. And similarly, what's happening in your family. But there's actually quite a lot of detail there. But you can get those out of the way at the beginning. Build up a relationship, get comfortable, get used to your voice, any language difficulties, and then you can get into the meat of the problem. But remember, first of all, patients come along, patients turn up to see doctors for quite a mixture of reasons. Some of them may be rather obvious. So they've got a symptom that they don't like, they can't tolerate, they want to get rid of. A pain, a cough, they feel sick, whatever it is. So that's the most obvious. There might be something somebody else has noticed. Classically, jaundice is not often noticed by the patient, and usually somebody says, oh, you look a bit yellow. So it might be somebody else's recognition of a problem. this might be a specialist referral, so it might be some other doctor has said, you've got a problem, you need to go and see somebody else. There might be specific worry about a diagnosis. There's a huge amount of medical information out there now, various media, internet and so forth. And patients just sort of latch onto this. Their friend, their relative has a problem, they suddenly think, oh gosh, I wonder if I've got that. So patients may turn up for that reason rather than having a specific symptom. Somebody else in their family may be worried. You know, why have you come today? Well, my wife told me I had to. That's not unusual. They may have been missing work, and that may be causing problems. And finally, there may be specific requirements of legal requirements, employment requirements, and so forth that cause the consultation. So it isn't as simple as the patient has a single symptom. Oops. So the opening question of the present history is terribly important because this is whether you're going to get the information or you're not. And it's crucial that you avoid it being too narrow because patients will answer quite literally. They'll only say or do what they think you want to know. But if you keep the opening question very broad, not at all judgmental, and don't lead the patient in a particular direction. And I think this is a really good opening question. I use this often word for word. What has led up to you being here today? So it's about today, it's about you coming to see the doctor, it's about what's happened, nothing about how long, it could be a day's problem, it could be 6 years' problem, it's just what has led up to you. And the patient will start where they want. They may start yesterday, they may start 6 years ago, they may start with their main symptom, but they may start with some very general comment like, oh, well, life's terrible, doctor, I don't know how I'm going to cope. Then you may get an idea that this is a much more general, even a psychological problem, and not about a specific symptom. The first answer to this question is going to have various formats, and it often starts with some phrases like, I have this pain. Well, that's a simple symptom, that clearly is the main problem. But it might be, I'm extremely worried about. Now, it might be I'm worried about the symptom, but it might be they're worried about something else. I'm worried that if I fall ill, I won't be able to look after my family. I'm worried that my brother just died of 40 of a heart attack and I might have heart disease. So there's all sorts of worries that might come out of this very, very open question. There might be something about worry in another doctor. So patients are trying to play down their symptoms, but other people have told them to play them up. Or you might get a bit of pushback from the patient that they should know why you should know why they're there because they've been referred. So they might be a bit tetchy, having been asked such a general question. But it's much better to do that than do it the other way around. Whenever you sort of finish up with the present problem, you should always recap and review and just give them another opportunity to say something else. Is there anything else you think is relevant that we haven't covered? It's a really good question. And other stuff may suddenly appear now that they feel comfortable, they're confident, they like talking to you, they see you're a nice individual. In general, going forward with the history, particularly the current problem, the patient should be talking more than the doctor. If you're doing most of the talking, you're probably not getting as much information as you should. And they're just giving you very simple yes-no answers, which is good enough. I mean, no, it's good as far as it goes, but it's probably not good enough. Students always get frustrated by patients who sort of don't seem to stick to the point. And the student wants to end up, or the doctor, with a nice logical, chronological history that's easy to write down and easy to present later. And life isn't like that. Rarely does a history come out like that. It comes out in bits and pieces, a bit here, a bit there. You go forward, you go backward, and then you have to reconstruct it. And that feels very stressful when you're starting out. How am I going to make sense of all this? The answer is just try and write it all down, either immediately or later, and then to try and reconstruct it, put in what's relevant, what isn't, and in the right order. You're going to have to do lots of checking and reviewing because the patient's ability to describe what's going on is very variable according to language, culture, anxiety, and these things. So you're going to have to just do lots of checking. Could I just check that? Sorry, I didn't quite hear you. Can you just repeat that? Are you really sure you said that? Those sorts of phrases. And letting the patient know that you're checking actually is a good thing to do. If you just ask the same question again, they'll think you're a bit stupid. Why didn't he or she hear it the first time? But if you say, look, I'd just like to check this, I didn't quite get this, or some sort of introductory statement that they know it's a review question, I think that makes it more reliable and more useful. So amongst all of this, there's a whole lot of non-verbal stuff going on. You're observing your patient for obvious physical signs, but you're also observing for what I call observable symptoms. So these are classic gestures that go with certain particular symptoms, usually pain. So for instance, a patient describing cardiac chest pain will often squeeze their chest themselves as they're talking. That's very classical. Renal colic, the pain of kidney stones, one of the worst pains a patient can have, goes from loin to groin, and it's often described or gestured by the hand going on the loin with the thumb at the back and the fingers at the front. And that can give you a bit of a clue. In heartburn, so as far as one can tell, heartburn and cardiac pain apart, and of course there's some crossover, but in cardiac pain the patient will squeeze the chest. In heartburn they'll rub the sternum with an upward motion as if the acid is rising. In sciatica they rub the buttock, go down the leg, and in midgut colic they squeeze their abdomen, bend forward, which is what you do when you're in colic. So these are all gestures, easy to miss, easy to observe, and they're not a make and break of a diagnosis, but they are helpful. So I'm talking about it in English, obviously. There are a lot of words that patients will use, which are actually ordinary English words that might be used in conversation. And you need to try, but also have some medical connotation. So you don't quite know when a patient says, I've got diarrhea, are they using that just as a general word they might talk to their friends about, or is it that they think they're using a medical word that you should understand? So you do need to clarify what patients mean by these. So if they say they have dizziness, is it just an unsteadiness? Is it a true vertigo? And these sorts of things. Pins and needles, is it truly the pins and needles of a neuropathy, or is it something a bit different? They say they've got a rash or a blister. What do these things actually mean? The corollary is when they use medical words. So those are English words that have a medical meaning. These are medical words that the patients will use because they think that's what they've got or because it's what they've had. And again, you need to clarify what they mean. So if they say they've got palpitations, does that mean that they just got a true irregularity of the heart? Is it just an awareness of the heart? Is it actually nothing to do with the heart? Similarly, say with constipation, do they mean that they don't go in as much as they think they should, or it's too difficult to pass stool, all these sorts of questions. There are many, many pitfalls in here. Don't just write, what I'm saying is don't just take it at face value, don't just write down what they say, just say, what does this word mean to this patient? What am I actually hearing here? I've said that the opening question should be very indirect, very open, but there are some areas where you want very direct questions, and in general direct questions are used for clarification. Did you mean this? Did you mean that? How many times did this happen? That's a number answer. There might be a yes/no answer. Be careful of direct questions because there is a tendency for a patient just to say yes. Whatever you ask. They get flustered, they can't quite hear what you say but don't like to interrupt. They may actually be deaf. That's a very common catch, that you think you're having a good conversation with a patient, actually they're not really hearing anything that you're saying, but they're just nodding nicely and saying yes, and you're writing it all down, you think it's all going very well. Actually you're getting no information at all. That isn't unusual. So you have to be very careful of with an open-ended question, if they're deaf, they'll just sort of look blank and won't answer. But with a closed question, they may just get the idea enough that they should just nod. So be careful of the very agreeable patient, the desire to please the doctor, and just clarify. Maybe ask the question the other way round and see if you get the other answer. And finally, of course, focus on the patient's problem all along. Don't pigeonhole them too early. Don't think this is just a cardiac patient or or a respiratory patient, but make sure you're actually focusing on the problem that the patient is telling you about. Along those lines, to try and think about how this is affecting the patient, the comparison with everyday life is very useful. The patient may tell you that, they may say they've had to stop work, or they can't go up to their bedroom upstairs, or whatever it is, but actually asking the question is not bad. So this one is a really useful question. It's actually part of formal anaesthetic assessment these days, or assessment for fitness for things like chemotherapy. Exercise tolerance. Simple question: how far can you walk on the flat at your own speed? Just very clear question. You're up on the flat, you're not going uphill, you're pottering along at your own speed, you're not rushing. How far can you walk? Now, patients, of course, have some trouble estimating distance often, but you may be able to, did you walk from the hospital gate to the outpatient room? These sorts of things to get an idea of distance. If you want to make it a bit more difficult, can you climb one flight of stairs going slowly without stopping? That's quite a lot of exercise for some people. They might never do it, but nevertheless it's a useful question. Have you been kept off work? Do you play any sport? Has that been affected? Has your eating been affected? Has your social life been affected? That might include personal relationships, going into the sexual history, that may be relevant. So these are simple questions. They may come out in the conversation. You won't ask all the patients, all of them, but they are useful to gauge the severity of the symptoms. Is it really a problem for that patient? So what's really important in the history? You've got to be careful that you and the patient are on the same agenda here. The patient knows what's important to them. That's not difficult most of the time, unless there's some major psychological disturbance. But they need to be allowed to say it, which is the whole point of being friendly, being open, giving them enough time, asking them the question again and again with review so that they get the confidence to tell you everything. And the doctor must avoid thinking they know what's best for the patient. I mean, you might know what's best for the patient, but you mustn't get into that mould, and you certainly mustn't let the patient know that that's what you're thinking. Some patients respond quite well to that, of course. They like the doctor to make the decision, but others don't. Remain problem-centred and not disease-centred. That's a really useful tip. But in spite of doing all of those things, being very open and friendly, lots of reviewing, lots of focusing on problems, not diseases, you can still end up with a bottom problem, where this probably won't be on the first visit, but it might be when you've seen the patient through to what you think is some sort of completion. You've taken a history examination, you've done some tests, you've found some problems, you've given some treatment, you've seen them for review, you think the treatment's worked, but nevertheless the patient still has the same problem that they came with, because somehow you got sidetracked. They came with a pain and you ended up treating high blood pressure. Or they came with some problem, musculoskeletal problem, you did some tests, you found a liver problem, you found they had hepatitis, you've had a long time treating it, and somehow you've forgotten the problem they first came with. The chances are it won't be that serious, otherwise it would have been obvious, but nevertheless you may not have helped the patient with their original problem. And just be conscious of that, that isn't that unusual. This is just a suggested schematic history of how to put it all together, of how you might document it. I put the past medical history at the top. I know that the conventional teaching is to put the main problem at the top and the past medical history further down, and that's absolutely fine. At the bottom of that list was a series of direct questions, or what the Americans call systematic review. There's a long list there of everything you can ask. In fact, the American list is probably rather longer, divided into systems. Some of this stuff will come out in the current problem. So if the problem is shortness of breath, you'll be asking those questions. If it's weight loss, you'll be asking perhaps some GI questions. If it's dysuria, you'll be asking some urology questions. Do you need to ask all the patients all the questions? And I think the answer is you don't, but you need to be aware of what the list is, and it will vary according to the scenario. So in an emergency presentation, you won't be asking all of this, although you could ask it later, and the patient's a bit better. you're doing a full assessment, certainly if you're learning and practicing, getting into the habit of asking this full range or a sample of the full range is very good. And what they really do is they act as a sort of screening function. Is there any other problem here, either relevant to the presenting problem, or not relevant but still important for the patient? You know, they happen to have had some rectal bleeding. Man in his 50s turns up with a problem of pain in the neck or a thyroid problem, and they say they've had some rectal bleeding, and you discover their rectal cancer that happens to be curable. Well, you've certainly done that patient a lot of good. So there are screening questions in here: transient loss of vision, transient loss of function, the bottom right. You know, patients having TIAs, transient ischemic attacks. You could give them some treatment and prevent them having a stroke. Well, that's a fantastic thing to do for that patient. So there is the screening function, but it's a lot there. It won't be possible to do all of it all of the time. But you need to understand the list and the reason for it. So pain clarification, what do I mean by this? Pain is a very common symptom in all areas of the body, almost, all bodily systems. And there's a bit of a structure to pain, which I think you should be able to ask about any pain. And it goes as follows. What is the site? That's pretty obvious. I've got a pain in the hip, I've got a pain in the head. But it may need clarifying, you know, where is the pain on the head? If it's, you know, half the head only and intermittent, maybe it's classical migraine, these sorts of things. So the site is not difficult. Where does it radiate to? Radiation is very, very important. Cardiac pain classically to the left arm, pancreatic pain classically through to the back, and so forth. What's the character of the pain? That's quite a difficult question. What does it feel like? Well, it's a pain doctor, isn't it? Patients will have trouble describing pain. I think we all do. And different patients appreciate pains in different ways, but there are classical descriptions, and they're useful. And you want to you may need to, having said you shouldn't be leading the patient, you will need to give some suggestions. Is it knife-like, gripping, twisting, these sorts of things. Severity is important. On the whole, severe pains are more important, certainly to the patient, and probably indicate more severe disease. Not always, but usually. A pain scale is quite a good thing to do. It's very easy, it's non-technical. You just say, well, if you imagine your pain, if it was just a little bit, it would be a figure 1. If it's the worst pain you can possibly imagine, and for women that might be childbirth, if they've experienced it, then it's a 10. So where do you put the pain on that scale? And the patient, it's actually surprisingly reproducible, this, and you can use it over time. So the patient comes in with a 9 out of 10 abdominal pain, and you watch them conservatively, and the next morning you come round and they say, oh, it's only 4 now, doctor. You sort of feel things must be getting better. So pain scale is very helpful, very quick. Most patients are going to cope with it if you explain it and write it down. The time course is important. Did it start suddenly or gradually? Is it continuous? Is it in waves? Classic biliary colic, which is intermittent pain, comes on quickly and goes off slowly. Again, these are slightly difficult concepts for patients, but you can probably talk them through it and get their useful information. And then the 3 last ones: what makes the pain worse, what makes it better, and what always goes along with it. I have this headache on half my head and it always comes after some flashing lights. Well, that's classical migraine. Those are useful questions. Looks a lot, but it's not difficult. It's really helpful when assessing pain. You probably almost need to do that every time you see a new patient with pain. What about the time course of the symptoms in general? When you're beginning to analyse them, they do give you some clue as to the cause. For instance, cancer symptoms tend to come on slowly. It's a slowly progressive disease. Chances are the symptoms will come on slowly. Whereas a vascular problem, a heart attack, a stroke, a pulmonary embolus will tend to come on quickly. Although more chronic vascular problems, angina, claudication, obviously may not do. And be careful of the slowly changing pathology that appears to present suddenly when it interacts with the patient's life. So when, for instance, a slowly progressive respiratory problem, maybe they only occasionally go upstairs when they, I don't know, go and visit somebody, and suddenly they go up the stairs one day and they suddenly find that they're breathless. You might think that's a sudden breathlessness and begin to think about sudden causes of breathlessness, pneumothorax or pulmonary embolus or something like that. But actually it's just their chronic lung disease is very, very slowly increasing, and they just happen to have noticed it that day. So time, of course, doesn't tell you everything, but it is helpful. So let me get on to some more clarifications. I put this right at the beginning as a question you could ask a patient when you're trying to just settle down and get the consultation going. Simple question, do you take any medications? But actually, of course, it's never as simple as that. And actually, I think the drug history has many pitfalls, and the more you look into it, the more you'll find for any one patient. So, as well as just a general, are you taking any medicines, you want to just ask where they're coming from. Another clinic, another doctor, a dentist, increasingly there'll be other involvements. There's over-the-counter medicines. In different countries they're more or less available. Patients will be taking all sorts of things they just bind because they think it might be a good idea. Make sure you've different forms of oral medication. Patients get confused, they think you're worried about liquid medications, surprisingly. And then there are all sorts of other routes of medication, inhalers, patches, creams, suppositories, sucking tablets and so forth. And patients may forget those or think you're not interested. There may be the medications you've stopped. So it's a bit like smoking. You can ask a patient whether they smoke, and they say no. And then you say, when did you give up? And they say, last week. That is that unusual, because they're proud of the fact they've given up. They think of themselves as a non-smoker, so they tell you they're a non-smoker. Of course, in terms of health, they've had a life of smoking in 1 week makes no difference yet. The same might be true of medication. They might have had a course of medication that finished a month ago, a week ago. They might not tell you, but it might still be relevant to their current problem. Remember that medications, they do a lot of good, but they also do a lot of harm, a lot of side effect, a lot of interaction. In the UK, we reckon that up to 10% of all adults in hospital are there because of some problem with their medication. They've run out of it, they've taken too much, the dose is wrong, there's been some interaction. That's a huge medical detrimental effect of medicine. So we do need to find all this stuff out. Do you ever take other people's medications? Well, I do take my wife's heart pills because, well, they're there and they seem to do me good. That's not unusual. And finally, the herbal and complementary medicines, which in conventional medicine we tend to think of these as harmless, but they absolutely aren't. Or some of them aren't. There are many herbs that have strong pharmaceutical effects. There may be side effects, there may be interactions. And patients may be vaguely ashamed of, if they're seeing a conventional doctor, they may be vaguely ashamed of taking these, so they won't tell you unless you specifically ask. So there's lots there to go through. Not every patient needs all of that, but you need to be aware of the pitfalls. And surprisingly, the more you ask, the more you find. So if you take your basic clerking, I know a patient with GI bleeding, and you say, are you taking medication? They say no. So you sure you haven't taken any painkillers? You say no. And then the next day they've had their endoscopy, you find they have a duodenal ulcer, and you say, you have got an ulcer. Are you sure you haven't taken anything, anything for arthritis, anything with, and you might give some common names of non-steroidal drugs. Oh, actually, yes, last week I did have a sore hip, and I went to the chemist, they suggested they were taking this, I wasn't quite sure what it was. And they bring out the packet, and it's a non-steroidal medication, and you've got the answer. So you have to keep, something about the drug history where the more you ask, the more you find, more than any other bit of the history. And similarly, there are clarifications with the family history. There's the basic, are there any illnesses in your family? That's a good question. Occasionally you're going to get a major genetic tendency like haemophilia, that will be quite unusual. There may be a more generic, oh yes, all my family have heart disease, and then you'll have to explore what that actually means. It's probably worth, in a full assessment, doing a basic little family tree of the first degree relatives, the parents, the siblings and the children, if there are any, and just draw them out in a little diagram, perhaps the sex of the relatives, of the siblings, of the children, and have any died or had major medical events. And occasionally you'll find some important stuff, young heart disease, young cancers, inherited neurological disease, or whatever it is. So that's a useful question. And then there may be specific questions once you're onto the diagnosis. So I put some examples there: gallstones, blood pressure, which have a sort of general familial tendency, but without specific inheritance. And then something like hepatitis B, which has a familial transmission, although it's not about genetics, it's about transmission. So then you may say, when you know what's going on, you may, on a second occasion, you may say, well, actually at the beginning, if you've got abdominal pain, you may say, does anybody in the family have gallstones? But with hepatitis B, for instance, once you know a patient has it, you then may go back and say, well, do any of your relatives have hepatitis B? And they say, yes, well, I've got 3 siblings and 2 of them, 2 of them have got hepatitis B. And then you begin to think this is a problem of transmission from the mother. So that tells you quite a lot. There are different ways of asking the same question. And similarly with alcohol. So alcohol causes huge health burden worldwide, more in some countries than others. In the UK, we reckon that the cost to the NHS of the alcohol health burden is at least £7 billion a year. So that's a huge amount of money spent on the detrimental effects of alcohol. Of course, in a lot of countries, that's balanced by a huge tax revenue from alcohol. So looking at it politically, it's not so simple. But nevertheless, as a doctor, you need to know about what your patients are drinking. And strangely, patients tend to underreport. With smoking, there may be a cultural difference here, I don't know, but in the UK, if you ask people, do they smoke, they will tell you an honest answer. If they say, how much do you smoke, they will tell you. But with alcohol, somehow, it's always underreported. Whether they're trying to deceive themselves, or whether they just forget, or whether they're ashamed, I don't know what it is, but it's underreported. So you need to just ask a bit more. Do you drink alcohol at all? Yes, no. If it's yes, what do you drink? How much? How often? And something about the circumstance. So isolated drinking is a pretty social habit. If you're drinking on your own, that tends to suggest more of a problem. And units of alcohol, that's trying to measure. Alcohol-related disease is all about the quantity of alcohol, not how it's taken. So you're trying to compare the amount of alcohol in different drinks. 1 unit is 10 grams of pure alcohol, roughly a pint of standard strength beer, 550 mils, say, a small measure of spirit, or an average glass of wine, those sorts of things. So you can compare. Now, most patients who drink don't get addicted, but nevertheless some do. And addiction of alcohol is very important because they tend to drink more, they tend to get into health problems, and if they have health problems from alcohol, they find it much harder to give up if they're truly addicted. So there are various assessments for addiction. This is one of them. It's called the CAGE assessment. It's an acronym of words, so you ask 4 questions, not every patient, but if you get some idea there's a problem. Have you ever felt the need to cut down your drinking? Have you ever felt angry when others criticise your drinking? Do you ever feel guilty about your own drinking? And do you have what are called eye openers? In other words, do you drink in the mornings? Most people who are drinking before lunch have a problem. That's a sign you have to have it to avoid physical withdrawal. And if a couple of those are positive, there probably is a psychological or possibly physical addiction, and then you'll need to, that's really important to know about and manage. Try and manage. This is a concept which I think is important, the retrospective history. So patients will tell you stuff. I've got angina, I've had angina, I've got epilepsy, I've got asthma, and you don't really know the certainty of that. We talked about them using medical words in a non-medical context, but you also need to try and work out why they're saying this. Okay, you can say, well, and what do they really mean by it? Was it just an off-the-cuff remark somebody made? Are they comparing themselves to some other family member or friend who has a apparently similar condition but which may not be similar? Have they been given the wrong diagnosis by a doctor? So it tends to be things with clinical diagnosis like angina and epilepsy, but maybe asthma, which is mistaken for all sorts of things. So going backwards, yes, you went to hospital, okay, so you had this test, yes, and what did it show? Or if they're talking about epilepsy, you know, what were these collapses like? Were they witnessed? And you can go back a long way to take the history. It doesn't have to be the current problem. It can be very useful. So finally, I think this is the final one, there are particular situations that stress out, particularly students, but in fact stress all doctors out, more so than just the general busyness of the clinical day. So the first one is angry patients. You may get an immediate sense as the patient, you meet the patient, that they're angry about something. It might be something very, very simple and practical, like the time they'd have to wait to see you. Both the appointment wait, a week, a month, but it might be the wait in the clinic, an hour, 2 hours, 3 hours, more. That's usually quite easy to diffuse, a little bit of time, show that you're a nice person. Be sympathetic. Oh my God, we really had to wait that long. That must be terrible for you. That goes a long way, just acknowledging it. But there may be other angers in there. There may be anger about their illness. It might be anger about some way that they're causing stress in the family. Maybe anger with themselves that they ignored the problem for too long and now they have incurable cancer. But there's all sorts of anger in there that you can, just talking about it, teasing it out, working it out, acknowledging often helps to get past the anger, and so you can actually talk to the patient usefully. Then there's the garrulous patient. That means the patient who never stops talking. This is the bane of all students' life, I think. How am I going to cope with this? I mean, there are two things that makes taking histories, well, many things, but there are two opposites that make history taking difficult for students. One is the patient who says nothing. You ask them a question, you just get a grunt or a yes, or they just say yes to everything, as we said. That doesn't really tell you anything. And then there's the patient, you ask the first question, and then there's a 20-minute story of all sorts of stuff, which is all true, but it's not relevant to the problem. It's just about their life and their family, and everything leads to everything else, and you can never get them back on track. And that's very difficult, and it's not, it doesn't get, well, you get more skilled at it, but it doesn't go away. And the trick here is really to recognise what's happening, have an eye on the clock, time passes quickly, and then you have to change your mode. So having said you shouldn't be interrupting the patient because you'll be preventing information coming out, actually you'll have to start interrupting and saying, yes, but, or can I just bring you back to it? And what you do is you come back to much more yes-no questions. You say, you get a whole story up. Did you have chest pain? And you just want the yes, no. They'll still start talking again, but you might get a yes or a no at the beginning of the long thing. Some patients are so garrulous, is the English word, that you cannot get a useful history. That is possible. You might have to acknowledge that. But there are skills and tricks to get past that. And there's a well-informed patient. This is a rapidly increasing syndrome, particularly when maybe due to the internet, where the patients, well, they either do know more than you do about a particular condition, particularly if it's a rare condition, or they think they know more than you do. And they come on with 10 pages of printout from some website. And they literally say, what about this doctor? A lot of doctors find that, well, students maybe, but doctors find that threatening. I think the trick is not to be threatened by it, and to say, this is everyday life, this is 2017, we have the internet, and you just turn it on its head and make it into a positive, not a negative. And you work with the patient to work through it. We are in the era where we generally should be working, we shouldn't be telling patients what to do, we should be helping them decide what to do, and having good information is part of that. So signposting, saying, well, actually, this website, I don't know this one, but if you want to know about this condition, here are 2 websites who are really good, really trustworthy, sensible stuff, no rubbish, no false information. So you steer them the right way. Indeed, I often ask patients, before any of this comes out, I say, do you use the internet? Now, of course, most people say yes. I say, well, are you going to go home and look this up? Yes. Well, in that case, can I suggest you look here and there? And you may develop your own information in your own hospital or indeed your own personal website with the relevant information on it. So I think the well-informed patient is actually a good thing, but you just have to acknowledge that and not be threatened by it. This is a common syndrome. The patient comes in with 5 other people. Or they're around the hospital bed with 5 other people. In the hospital ward, it's probably a bit easier to manage. You can just probably send them out. But in the clinic, well, you might say, sorry, only one could come in, but I never particularly mind how many people are in the room within reason, but I do like to know who they all are. I will spend time saying, well, who are you and who are you, and I want introductions to all of them. And occasionally you find, I found patients coming along with another doctor just to sort of check some friend or something. Now again, you shouldn't be threatened about that, you should be able to cope with that. You do need to know what's going on. I think that is quite important. You also need to make sure you're focusing on the patient when there are all these other people around. It's very easy to get sidetracked or spend a lot of time talking to other people. The patient gets ignored. You need to really hold their attention. But nevertheless, the other people may have useful stuff to say. And of course, we know there are quite good studies that patients who leave the outpatient consultation remember about a quarter of what's been said to them. Usually it's not more than a quarter, sometimes rather less. They get flustered, they can't remember, there's technical jargon, so having a witness there is quite helpful. The next thing, which isn't on this list, perhaps I should put it, is the tape recording of the whole consultation on the phone. In the UK, you're not allowed to, the UK law says you can't do that actually without permission. Although people do, I'm sure, they leave their phone running as they walk in the room. I think actually, again, that's a good thing. You shouldn't be threatened by it. If you're a good doctor doing good stuff, why does it matter if it's recorded? Indeed, you could say it protects you. And if the patient listens to it quietly later, they'll be doing better than their memory of 25%. So I think all this stuff is actually fine, but you need to know what's going on. Interpreters are a challenge in cities, usually big cities with big immigrant populations and lots of languages. So where I work in East London, we're highly multicultural, multi-ethnic. We have lots of races. The common languages are Bangladeshi, Somali and Vietnamese. And we have hospital interpreters in those languages. The Bangladeshi interpreters work 24/7 in fact. But there's 100 other languages that our patients might speak. We use relatives who are interpreters, but often they come with very young children. You've got to be careful of the ethics of that. And it's just a different skill. This nice open-ended, what they'd like to you coming here today, you ask the interpreter asks the patient, they have a 5-minute conversation, and you get back a one-line answer. You have absolutely no idea what's going on. So, again, a bit like the garrulous patient, the consultation through the interpreter tends to be much more direct questions. Is it this? Is it that? Yes, no. It's less satisfactory, but it's the best you can do. And using family members as interpreters introduces its own dynamic about what are the family keeping back from the patient. So professional interpreters are better if you can do it. So I thought that was the last bit I've got out of order. So we're getting now onto symptom analysis. So this is when you're constructing your diagnosis. You're probably going to integrate physical science as well at this point. History taking an imprecise business, very dependent on personal relationships, language, vocabulary, education, all sorts of things. So what can we rely on, what can't we? And I've come up with this concept of hard and soft symptoms. So a hard symptom is one which is very real, you're not going to mistake it, it's not going to get lost in the language, and it really means something. And I think this is the best hard symptom, pneumaturia. Quite an unusual symptom, but it's just used to illustrate the point of what is a hard symptom. Pneumaturia is air in the urine. The patient often won't tell you that. They might volunteer that it hisses or bubbles or stops and starts, but you might get it on a direct question when you're thinking there might be a problem. And the problem is a fistula. If they have pneumaturia, they have a fistula from bowel to bladder, 100%. The symptom means the problem. All you've got to do now is find it and find the cause. So that's the best example of a hard symptom. There's some others here. Fortification spectra, the flashing lights before migraine, rigors, the shivering associated with fever, chattering of teeth. You can imitate a rigor to a patient saying, does this happen? The bitten tongue of the previous seizure, that can't be faked. So a collapse with a bitten tongue is probably a seizure actually, and whatever else you can get on the history. And the sudden severe headache of subarachnoid hemorrhage, and the pleuritic chest pain of pleurisy, and the itching that goes with jaundice. So these are very hard symptoms that are very clear, not difficult to elicit, and really mean something. And then there's a whole load of soft symptoms, which are pretty woolly, difficult to know what they mean, both in terms of what the patient is really experiencing and what they mean in terms of pathology. Dizziness, very, very vague word. Tiredness. Most patients who are more tired than they want to be don't have an illness, a physical illness. Back pain is very non-specific, headache, wind. These are all very woody symptoms. Doesn't mean you don't elicit them, but they're going to be hard to rely on in terms of diagnosis. There's a question of how much negative information you rely on. In general, we get positive things. I have this pain, I have jaundice, get the time course, the character, and these things. But what about the negatives? These tend to be brought out by yes, no, or binary two-way answers. And again, I'll come back to the subarachnoid hemorrhage because it's so important and such a specific syndrome. So if you're worried about subarachnoid, you say to the patient, did your headache start very suddenly or did it build up gradually? It's a binary answer, two-way answer. If they say it built up gradually, very unlikely they've had a subarachnoid, because a subarachnoid is a very sudden event. Assuming you think they're giving a reliable answer. Similarly, if you suspect angina, it's a clinical diagnosis initially. Is the onset of your pain predictable, or does the amount of exercise needed vary? If the amount of exercise needs vary, it isn't classical angina, it may not be angina at all. Classical angina is entirely predictable with a set amount of exercise. So these are useful negatives. They come later, you're building up the diagnosis, you may come back to them, these may not be questions on the initial history, there may be clarification questions later. Two-way answers, is it this, is it that? And when you're analysing the symptoms, I think most of us believe, as much as medicine's a science, we should be coming up with a logical analysis, put in the positive data, put in the negative data, this must be X because of Y. But actually some of the time we're doing the top, we're doing pattern recognition. This just sounds like whatever. And of course the good doctor, the experienced doctor, will be doing quite a lot of the first. And that's probably right, provided you're not over-diagnosing or doing it too early in the consultation or in the process. If you do it too early, you often get it wrong, you get focused, you get narrow, you exclude other possibilities. But on the other hand, the very experienced doctor will just spot stuff that others won't, because they haven't built up that pattern recognition yet. So both are valid, and you'll use them in different quantities in different situations and with different experience. So this is the last slide, or the second last. So what about history taking? Well, I think it is very skillful. Because, there's a lot to say about it, surprisingly. It isn't just about talking and getting answers. A lot of skill, a lot of practice. It's all about practice. The more you do, the better you get. And one of the things that as a senior doctor you don't do much of is work with you actually see your colleagues, you see your trainees in action, and you're supervising them and teaching them. What you don't often see is your colleagues in action, to work as individual consultants. When I do see my colleagues in action, I'm reminded that the variability in the skill of history taking never stops. Some of my colleagues are fantastic, some of them are actually not very good. They might be very good doctors in other ways, skillful surgeons or whatever, but they're actually not very good at history taking. So I think it is very skillful, you can learn it, you can get better and better. It is variable, both between doctors and with the same doctor over time. So two doctors take the history, they get different histories. The same doctor takes the history in 2 different weeks, you'll get a different history. Now, if you're a scientist, you might say, well, that's just rubbish data, I'm going to ignore it completely. But actually, it just means you have to be conscious of it, you have to work out what you're going to believe and what you aren't, and just work with that variability. It's infinitely interesting. Every single patient is different. You never get a standard. And that just keeps the enthusiasm going, and should do if you're a good clinical doctor. And it's very rewarding. I think it's as rewarding and a nice history that leads to helping the patient. Well taken. It's very satisfying. It's just as good as finding a rare physical sign or doing a complicated, complex technical intervention. And as I've said, it's very important. Just leaving aside tests, 80% of the diagnosis on the history. So finally, thank you to various people, the local Elsevier team, the UK Elsevier team for organising this trip, your college for inviting me here, you guys for listening, and good luck in your careers. Thank you. So without questions, big audience, questions we go through difficult, but happy to have any questions now. Alright, we got some free-form questions, right?
I'm very humble and honored to be the one making the closing statements on Dr. Glynn sir's talk. It was very indeed insightful, especially the different types of patients. It is often said the best way to thank an author is to write a review to his book. And on that basis, on behalf of the students, I would like to thank you, sir, for taking the efforts to keep up the legacy of this oldest clinical book. This book has been an outstanding source to both undergraduates as well as postgraduates. It has provided an integrated approach such that new methods are grafted onto established contents. Ethics, approach to the patient, and doctor-patient relationship are a few peculiar chapters discussed very well. So your presence has been a great motivation to these budding medicals. We thank you for being here. We would like to ask a few frequently asked questions by the students. The first question goes like this. With the recent advances in technology, there has been a shift to the approach of medicine from being clinically oriented and to being now investigation based. So how would you compare both?
And obviously, there's a huge amount of investigation you can now do from blood testing to scanning and so forth. Can you hear me? Yes? I think the two are complementary. So there's a huge amount to discover from testing which you're never going to get from history and examination. But testing is not an exact science, however much we try and make it exact, and the human body is infinitely variable. So testing will throw up abnormalities, for instance, blood testing normalities are defined statistically, patients may be just outside the statistical range, but nevertheless be normal for them. You know, is a man of 6'10", is he got some endocrine disorder, or is he just very tall? Often they're just very tall. So testing will throw up abnormalities of a standardized nature which is not particularly relevant to that patient. And that's what you as a clinical doctor have to integrate, and that's where you come back to your history and examination. What's this patient's problem? What do the tests tell me about helping them with that problem? Sometimes it gives me the answer, sometimes it doesn't give me the answer. And a lot of the time I actually don't need the test at all. And that's the trick, is to be confident in your history examination. So you say, I know what's wrong with this patient, or I know what's not wrong with this patient. I actually don't need any tests to tell me. Tests are not going to add. Therefore I'm not going to do anything. You need a lot of confidence to do that. You need to protect yourself by writing down that thought process. My judgment is this. I have thought about it. And actually, if you write down what your thought process is, it's very hard to anybody to challenge you. Because in the end, you've made an honest judgment.
Thank you, sir. It's really a good point you made. That documentation is one of the most important things. We have another question. That over the years, comparing like 5 decades down the line and today, there has been a deterioration in the doctor-patient relationship. So in your opinion, what efforts can a doctor take consciously to minimize the deterioration?
I mean, life changes, and you could say there's been an improvement in some relationship. Again, this will vary from country to country, but if I just think of the UK, go back, say, 50, 60 years, the doctors on the whole were terribly authoritarian. They just told patients what to do. And for some of the time that was fine, but a lot of the time it absolutely wasn't right and wasn't appropriate. So I think there's been quite a lot of improvement. Okay, we've got less time, we may spend less time talking to patients, we may rely on tests, we may not see the patient at all and talk to them on the phone or by Skype. So this is just part of the changing pattern of life and medicine. Fact is that medicine is a human interaction at some level. That's never going to go away. I think I can honestly say that. However much you can slide through a scan and have a diagnosis, sit at a computer with a computerized questionnaire, that may all be useful. It doesn't take away the human side of it, which it is our duty as doctors to hold on to. If we as doctors hold on to it, then in the end it'll be all right. I believe that.
Thank you, sir. We open the questions to the audience now. If you have any questions, please raise your hand.
So we just recently started taking cases, and there was one particular difficulty that I faced. There were certain aspects of the personal history, such as the addiction history, alcohol history, the bladder and bowel history, or the sexual history, which a doctor, actually a student might be intimidated to ask, or the relatives say that the patient may get irritated. How should we go about asking such questions?
So just asking my clarifying question here. So you're worried about things that may seem quite personal?
Yes.
Yeah. That's always going to be difficult at student level, partly because when you're doing it as a doctor, you've got the confidence that you're asking these questions in order to help the patient. As a student, that's less certain. Okay, you may be taking the history in order to present to a senior, and then that'll, in due course, help the patient. But in the end, you're just learning, and it will be difficult when you start. I think if you didn't think it was difficult to ask those personal things, there'll be something wrong with you. So I'm pleased that you're finding it difficult, because that shows you're a nice human being. But as we get further, as you start actually being responsible for patients, I think if you don't treat the personal questions as any different from any other, then the patient won't either. You just ask a series of questions that you need to know the answers to, then the patient will give you an honest answer, probably. You might clarify them a little bit, saying, I'm sorry I have to ask you this, or in order to understand this fully, I need to ask you that. So a little bit of clarification may be sensible. But just being straight, this is what I have to do, I have this series of questions, I'm getting on with it, I'm trying to help you, it usually is fine.
Any other questions?
Hello. Yeah, sir, this is a scenario which most of the undergraduates face, especially during exams when we have a standard patient to be questioned for history. Sir, when a patient is asked repeatedly again and again by multiple students, in that scenario, is there any way we could improve the whole process and make it more productive?
This is sort of too many students, not enough patients with classical histories that every student wants to talk to. I'm not sure I have the answer to that. I suppose you could. It's not a substitute, but making videos of a consultation so that you can at least hear what the patient is saying in their own language, in their own way. You know, this is a classical presentation of X. That may. It's still not the same as doing it yourself by any means. You don't have that tension of trying to make the whole thing work. I think acknowledging to the patient that you're incredibly grateful that they're seeing the 6th student of the week, that helps. Showing you're a nice person, always good. I'm afraid I'm not sure I've got any other answers really. Some patients do get overloaded, and that's just how it is.
Do you have any other question?
Hello, doctor. I want to know what part of medicine do you think we've got completely wrong? So something like we may look back after 50 years and think that we actually did it, it was a bad idea. I mean something like empirical theory where empirical administration of drugs where we give broad spectrum and maybe we can localize it more.
Gosh, that's quite a difficult question. I suppose one of the ways to think of that is what are we doing now that we were, what do we stop doing now which we were doing 50 years ago? That's quite a difficult question, isn't it? Because some of it just is around new discoveries and new knowledge and new techniques for investigation. So some of the detailed, I don't know, if you think of thyroid disease, we used to do lots of very complicated thyroid tests and stimulant tests, and now we just do one test and get a simple, quite accurate answer. So there's something about testing. I think what we may understand better is some of the so-called functional diseases. So in my area of gastroenterology, we have a whole load of patients in the UK, up to half the outpatients have functional disease where we can't demonstrate a problem. And we struggle to convince ourselves what's going on, and we struggle to convince the patient that there isn't anything serious going on. I think technical advance, understanding, measurement will help to resolve that. But I think I'm not very good at predicting the future. Personalised medicine, where you use the patient's genetic, particularly their genetic profile, to try and tailor medications or dosing specifically to them, may change a lot. I mean, dosing is incredibly crude, isn't it? We give most patients the same dose. We might base it on weight a bit, kidney function, a few things, age, but we don't do it very much. That would seem quite surprising that we couldn't do better on tailoring dose to individual people if we knew how to do it.
Thank you.
We have another question.
So about history taking, you were saying there were certain aspects such as smoking, alcohol, and if the patient takes certain drugs, it is quite possible. I mean, if there's someone accompanying the patient, they may not feel comfortable saying that because of pressure, I guess. So how do you go about that?
That's interesting, yes. So we talked about the accompanying people, and I think on the whole you should welcome them, but you're absolutely right. There may be things you want to talk to the patient about where you either sense that there may be a confidentiality issue or you actually spot that there is. You either have to leave it for a second occasion and then deliberately see them on their own. If it's in the ward, you can probably send the people out relatively easily. If it's in the clinic, you might be able to do something like private examination. Hey, well, I've got to do this examination, I need you all to leave, please. And then you ask the questions there. Particularly around sexual history, so a young woman, are they sexually active or whatever it is, or smoking perhaps won't be so confidential. Alcohol history, curiously, you might need the opposite. The relatives reporting of the alcohol history may be more accurate than the patient, so this works slightly two ways. But being conscious of that and managing it is important. You're absolutely right.
Do we have any questions? So I would like to end up with another question. So you being a specialist in clinical nutrition, what will be your take-home message to the students while they elicit history in patients having chronic diseases, especially hepatic diseases or chronic kidney diseases, because they have a relevant dietary history?
I think on the whole as doctors we've been not very good at paying attention to nutrition as part of illness, both assessing the patient's broad dietary history. I didn't mention that there at all, so sure I should have done. I think we're not very good at understanding the interaction of diet and getting better. The nutrition is important as an adjunct to treatment, or indeed it may be the only treatment you need. Diabetes, Crohn's disease has a nutritional treatment and various other areas. So I think you spend a lot of time learning about nutrition in your basic physiology and biochemistry, and then a lot of time ignoring it when you become a clinical doctor. So don't do that. I think that's the message. Just remember that we're all here because of what we eat. It's bound to have effects on our life and therefore our illness, both in a positive and negative way. And just holding on to that information and constantly reminding yourself and others of it will be good.
Thank you, sir.
So, thank you, sir. I'm sure that the session was pretty enlightening for all the students sitting here in the crowd. I would now like to call on our very own Dr. LOPA MEHTA ma'am to felicitate sir with a momentum. Elsevier, our very own GSI, Sushrut Ingawale, has been extremely active in organizing similar events such as quizzes, seminars and orations at G.S.MEDICAL College, as well as many other institutes in and around Mumbai, as well as many online events. G.S.MEDICAL College and Elsevier would like to congratulate and honor Sushrut Ingawale on successfully completing 1 year as Elsevier Student Ambassador for the year 2016-17. I would like to thank our Dean, Dr.manu sir, and Dr. D.N. ma'am, the Head of Department of Physiology. I would also like to thank Dr. Munira Hirkani and Dr. Sharad Patel sir and the entire Physiology Department, without whom this event would not have been possible. Last but not the least, we would like to extend our heartfelt gratitude to Elsevier for helping us organize this event successfully. A stall has been arranged just outside the MLT auditorium where you could buy copies of Hutchinson's textbook of medicine signed by Sir personally. Thank you and have a pleasant day ahead.